All right. Well, welcome everybody. Thank you for spending your evening with us. My name is Lindsay Ryback. I'm the Senior Product Manager of Compression at L&R USA. And we are so excited to have our friend Deana Benjamin with us today in Santa Fe, New Mexico, here to present on the topic of upper quadrant lymphedema, really focusing in on breaking the barriers of basic CDT. So with that, I'm going to hand it over to Deana and let her further introduce herself and jump right into it. So thank you for joining, and we hope you enjoy.
Thank you, Lindsay. And thank you everyone for tuning in this evening. My name is Deana, as Lindsay stated. And I currently work in Santa Fe, New Mexico with Christa St. Vincent Sports Medicine. I'm a clinical manager there. I did start my career off at the Nebraska Medical Center in Omaha, Nebraska. And was there for about 10 years and then now have been here for about 10 years. All right, I also am founder and president of a nonprofit in New Mexico called Everything Lymphedema and Lymphedema. So the learning objectives for tonight is I really wanted to kind of offer something that I felt we were lacking in our education. So I kind of tried to look at the upper quadrant and what things me and my team do in our current practices that we weren't taught in our certification course and weren't really taught in school. So some things that we've kind of learned along the way, some special kind of case studies that we've had, and special training from CEU courses for various manual techniques that we now use with our lymphedema population on a regular basis. So with that, I did kind of want to go through, basically some diagnosis, but really focusing on the treatment portion of this, not just manual lymphatic drainage, but all types of manual therapy that we're doing with our patients, and then also quite a bit on compression. And I'll touch just very briefly on exercise and education for our patients. But yeah, I hope that in watching this, that we can share with each other treatment ideas and hopefully pick up something new. So just briefly, I'll just mention the types of lymphedema. We should all know this, of course. There's that primary type that's hereditary or due to an anomaly. We don't get a lot of primary patients. We do get some. We get a few kids, a few adults. We do get, of course, lymphedema more in that primary section. But most of our patients are secondary lymphedema. As we know, it can be from any trauma to the lymphatic system, either lymph nodes being removed or any damage to that system from trauma. Could be a burn or a surgical trauma, a mechanical obstruction, blood clots, any of those types of things that are causing damage to that system. So I want to start off with just showing this is a very simple picture of a secondary to lymph node removal. This is very mild edema, but I want to note that even in this picture where it's very mild, you can see the lack of wrinkling in her right arm, which is on the left side of the screen there. Whereas on the other side, there's a lot of wrinkling and loose skin. You can see more fullness through the elbow area with those creases in the elbow and fullness in that forearm. She thankfully doesn't have much swelling in her hand at this time, but she is getting it throughout the upper extremity. So I wanted to show this picture of just a reminder that lymphedema isn't always like those really, terrible stage 3 or 4 pictures that we see a lot. All right, and so these are 2 different patients that both have mechanical blockage. We tend to get a lot of patients with mechanical blockage into our clinic. Often they're looking for comfort or just to reduce the compression to keep their range of motion, that type of thing. And, I talked with my other therapist recently about, I wonder why we have so many patients with mechanical blockage. And I think there is, a little bit more in Santa Fe, New Mexico, people are open to alternative treatments that often aren't very successful. So I think we do see some more of that here. In these pictures, you can see that the swelling tends to be a little bit more proximal as opposed to distal. And then often there is this orange peel appearance too, which I'm going to zoom in on. This gentleman here too, you can see less in the hand, certainly more swelling proximally. So he does have that mechanical blockage in the axilla, just as the previous picture. You can see some of the lesions here forming in the chest, some hyperpigmentation of that chest. And then here's a picture of each of those close up. It shows that pewter orange, that orange peel appearance to the skin with that dimpling. We see that both in the upper extremity and lower extremities with mechanical blockage. They can also be a little bit more pitting from what I see, but so can other types of secondary lymphedema. Pardon me. We often do provide manual lymphatic drainage to our patients with mechanical blockage. We do have a discussion with them about, the precautions of performing MLD. Generally, patients want to continue with it because they feel better. And we do find that we can move fluid and reroute fluid, even if there's a blockage there, generally, unless things really, really progress to that end stage. We do really limit or avoid deep techniques in these patients because we know that can spread the cancer cells. So we do avoid that. The next picture here is a patient that has chronic DVTs. This particular patient has a condition that causes DVTs over and over. She has some supraclavicular blood clots there, as well as severe thoracic outlet syndrome because of it. They did remove her rib and nothing really helped. I was able to reduce her pretty well with some manual lymphatic drainage. It was very hard to get her to wear compression. And so she is currently looking at some surgical options. As you can see, that's quite severe edema there. And then I just wanted to show a couple pictures of some post-surgical. So this is a gentleman of ours that was going through gender reassignment surgery. So this was actually taken right after surgery for a phalloplasty. So that's where they did take full thickness of the forearm to create the phallus. And then they skin grafted from the thigh up to the forearm. So this is right away, you can tell that things are not healed yet. And then these next pictures show, pardon me.
And Deana, I'm going to quick interrupt you for a second. We had a question come in asking, are you suggesting that MLD can spread cancer cells?
Well, as far as most of us know in the research, it's kind of like we're not positive. Most of the studies they've done recently that I've seen, they're not finding that MLD does spread cancer, but it's a pretty hard thing to study. Most studies are leaning towards, if the lymphatics are running fast and running well, that's beneficial and not going to spread cancer. When I first started doing this, almost 20 years ago, there was a lot more hesitation with doing it because we were trained that massage or soft tissue mobilization did spread cancer cells. So our baseline rule here in our clinic is if they're receiving chemo or radiation or a treatment like that, we do not hesitate performing manual lymphatic drainage. If they have metastatic cancer and they're not doing any treatment whatsoever, we have the talk with them. We say there's not a lot of solid research on this. Do you want to proceed? And I would venture to say 99% do. So I think it came out of concern, years and years ago too, of, when you're a lymphatic therapist, a lot of your patients have reoccurrence. It's just what happens. And so, therapists kind of started to wonder, am I making them worse? Is what I'm doing spreading the cancer or making it return? So I think it was out of extreme caution and care that they really are trying to prove without a doubt that we do not do that. It's probably a longer answer than you wanted. Does that answer the question though?
It seems so. Thank you.
Okay, yes. Okay, so same patient with the phalloplasty. This is before any therapy, but after he started to heal post-surgically. We do get patients in our clinic with pretty severe burns. We just had a couple young gentlemen, both with some pretty severe work burns. They presented very similar to this, a lot of skin grafting, a lot of myofascial adhesions, and then some secondary lymphedema. I don't have a picture of that, but. And then this patient here, this is a patient who actually underwent surgical debulking. So they basically went in and kind of did some liposuction and then removed the excess skin. So there's an incision from the wrist all the way up to the axilla. And this patient did have pretty severe lymphedema for quite some time, had tried numerous things to manage, and was very compliant and really kind of followed all the rules and really struggled still with some pretty severe swelling. So she had made the decision to go and have this surgical debulking done. So I will show more of her later. And then I just wanted to point out too that, of course, as we know, lymphedema does not just affect the upper extremity, it also affects the trunk. I included these two pictures for a specific reason. As doctors sometimes don't see, but we as therapists see because we're having our hands on patients and we're really looking at them closely. If you look at this picture of the swelling in the trunk, it's actually the side with the full mastectomy that has the lymphedema. You can see that upper quadrant on the left of the body or right of the screen, that's far more swollen than on the opposite side. So, for untrained eyes to look at this picture, you might think, oh, it's the other side. Same thing here with the picture of the breast. It's actually the smaller breast that has the lymphedema. You can see the hyperpigmentation, some fibrosis in there. And then if you look at the distal part of that upper quadrant, there's also more swelling here than on the other side. So some stuck tissue, indurated tissue. So it's really important to not just look and say, oh, which side's smaller, but really looking at what was done surgically and what other is presenting in the patient. Okay, so let's get into the treatment part more. So we were all trained, or most of us were trained if we're treating lymphedema in complete decongestive therapy. And we know the parts, right? We know it's manual lymphatic drainage to reroute that fluid. We have compression to reduce and maintain that reduction, and then teaching patients how to care for this themselves. One of the major components is that manual lymphatic drainage. And this, consists for probably 75% to even more, 90% of our treatment in the clinic. And I'm not going to talk about this a lot, mostly because we were all trained in this. If we're certified, we know how to perform this part. And although it's really important, I really want to focus on some of the other things that we weren't taught in our certification courses. So kind of going beyond that basic CDT. So I also just feel like I have to mention those vasopneumatic pumps. They're out there. There's the basic ones and there's the advanced ones. The basic ones really aren't meant for people with lymphedema. They're meant more for vascular issues. So if you're looking into something like that, it can really help the patient be compliant and be close to what we do in the clinic and improve that lymphatic flow, reduce the risk of infection. There's two, big companies in the US that I put my name behind. FlexiTouch, especially because they have a lot of great research, big case studies and printed in JAMA, and also Lymphopress. Okay, so starting to talk about some of those other manual therapies that we do. So you may do some of these or all of them, or maybe none of them in your clinic, but I think it's good to just kind of go through them. Most of these take some special training outside of our certification courses. And so these are kind of the ones that I'm going to go through here. And we're going to start by looking at some cupping. So when we do our cupping in the clinic, it's very light and it's always going in the direction of that lymphatic flow. We are doing it to lift that tissue and improve the flow between that interstitial space. So that's going to help move the lymph, as well as lift some of those myofascial adhesions. So that is that patient that underwent the phalloplasty. This is about mid-treatment. And I'm going to show you here, he had some pretty significant keloids around the wrist and some really adhered tissue. So there, I'm not following the flow of the lymphatic system, but I'm really working on those keloided areas, trying to lift and soften that tissue. So our goal with cupping is not to bruise. If we're doing cupping that aggressive, we could really worsen their lymphedema by causing trauma to those vessels. So it's really a quite gentle technique to move fluid. And I do use this all over the body, axillary incisions, lumpectomy incisions, mastectomy incisions. These were just the videos I happened to get to show you guys. All right, and then I wanted to get into kinesiotaping. So most of us here know how to do the fans for lymph drainage. I think they're really beneficial. They're non-bulky, they're inexpensive. Patients can, don and doff them themselves, learn how to self-tape, and they have really good results. So, this is kind of a standard fan. Another patient here actually had a shoulder injury on top of her lymphedema, and so got kind of a big bulge of swelling there at the upper arm. So I was really trying to target that area. So adding 2 fans. She's had lymph node removal on both sides. So therefore taking that fluid only down to that inguinal lymph node region. So those are the pretty common, those fans. We do a lot of basket weave taping in our clinic also, especially if the edema is more fibrotic or dense. The basket weave really tends to soften that area. I think of it almost the same as kind of chipped foam. So it's that, potch marked effect and then not. So it really helps just kind of break that up. So we found that technique to be useful. And then we do a lot of layering and just kind of experimenting with our Kinesiotape too. So this here again is the gentleman with the phalloplasty. You'll see that there is a basket weave over that keloided area at the wrist. There's also a basket weave over the thumb. And that's where there was a lot of swelling. That was the most stubborn part to reduce. And then we followed that up with double fans from the dorsal of the hand up to that healthy area just before the elbow. So one of my take-home messages would be don't be afraid to experiment, and certainly to layer. And then another one of my favorites here is the witch's hat. This consists of making basically a cross or a T with strips of that Kinesiotape, and then just, then just holding it in place with a rectangular piece. This allows the patient to self-mobilize an adhered area at home. So they can hold on to that tab and really move it up and down and sideways and diagonally, and whichever way they need to help improve those adhesions and restrictions. So the picture on the right, that is a witch's hat on top of a well-healed port site. So it's not something you'd want to do, on a port that was just removed. But once they've healed, sometimes patients will get, some really bad scar tissue there and some pain when they're moving their arms. And so this is a way that they can help on their own, start to mobilize that area. Okay, so next we are going to move on to some iStim, instrument-assisted soft tissue mobilization. So again, this of course takes specialized training. We were all certified in the Hawk grips type of iStim. This again is a port site that was causing some pain for this patient. Well healed, port had been removed for many weeks. And so just going in and doing some quick swipes through that, this particular tool is called a pencil tool. And basically what that iStim does is causes a micro trauma. So it breaks up that scar tissue by actually causing a new trauma. But then as that scar tissue heals again in nice, neat rows, it's more extensible and not so painful. We use caution with this technique, especially with somebody who had a large number of lymph nodes removed. Techniques like this that are deep and aggressive, we do them after, like 30 minutes of manual lymphatic drainage, and then perform another 20 minutes or so after. We really want to make sure that we have all the lymphatic fluid moved out of the way before we do this, and then we want to give it someplace to go to. We'd never want to do a deep technique right at the end of a session and not give that fluid that we're kicking up somewhere to go, basically. You do have to be careful with skin integrity. So for instance, the patient with the phalloplasty, we did attempt to do iStim on that adhered skin on the forearm, and his skin was just far too fragile for it. Anytime we attempted, it would basically kind of start to break open, and we'd have to stop right away. We did want to try that because we thought it would be really helpful, but just was not strong enough for that. So. Okay, and then the last one I wanted to show you of these kind of deep techniques is a video. This is kind of the ones that we learned in certification course. I learned these ones through the Academy of Lymphatic Studies. So I just wanted to show a quick video of them. It's the skin rolling. A lot of us will do that to break up adhesions. Certainly after, a mastectomy, patients can get a lot of adhesions through that chest wall. The thumb push, we also use a lot when indicated, and that S wave. Just a good way to get that fascial tissue stretching and moving. Okay, so those were most of the kind of deep techniques that I wanted to show you that were kind of basic. And now I want to get in specifically more to axillary web syndrome and cording and how we treat some of those patients. And then a little bit too on some more just fascial restrictions and the anatomy trains. Okay, so let's move on here to just some general information about axillary web syndrome. This is generally called cording. Often in the literature, you'll see that, they say, well, we don't really know why this happens. And so I always tell my patients like, well, I think I know why it happens, but, it's just a theory. But, we get this scar tissue that runs often from the elbow all the way through the armpit into the trunk. And, my thought is because of our very unstable ball and socket shoulder joint, there's so much movement in that shoulder that when we do a large surgery like a mastectomy or an incision in the axilla, I think the body's just kind of being overprotective to that unstable joint. So it's really laying down extra scar tissue. Or I kind of explain it to my patients like it's putting down anchors, right? Trying to keep that shoulder stabilized. And I also tell my patients sometimes, your body doesn't know that this was a controlled surgery. Your body could just as well think that you're walking through the jungle and got a huge gash. So it's really trying to protect you by laying down the scar tissue. So one of the reasons that kind of goes into my theory of that, one of the patients that I've had with some pretty severe axillary web syndrome was a violin player here in town. And her axillary cording was actually rotated from the axilla around her arm. So it was the first time I had ever seen that and have never seen it since, actually. But it was cording just like you would see anywhere else, except for going to the elbow, wrapped around that bicep region, around to the tricep. Thankfully for her, I was able to release that and break that cord in the very first session. And she gained about, 30 or 40 degrees of range of motion instantly. So kind of seeing how her, because she played the violin and was constantly rotating her arm, that's the way that the cording went. That was the body's protective mechanism for that constant motion. We also see truncal cording in the clinic. And I think that's something, unless you know to look for it, you might not see it. Patients might describe some pulling that also goes down through their trunk, but really kind of trying to look for that too. And, sometimes cording doesn't bother a patient too much. Sometimes it really restricts their range of motion and causes that pain and that pulling. Often I think a patient is not really aware what's causing it when they come into the clinic to see us. Okay, so I'm just going to show a few pictures of axillary web syndrome. So this one here, you can see kind of a thick band starting in the axilla and running down the upper arm. And then in this picture here, you can also see a couple bands there and some tiny bands. We often get these tiny little bands in there too. And here is another patient. This patient, unfortunately, her cording was really thick and really sensitive. So I'll show you a technique I used with her in a little bit. But she had severe hypersensitivity when starting and some really stuck patches there in the axilla. Actually to the point where we had her work with the desensitization kit for quite a while, different types of materials and fabrics, and just getting that area to be able to be touched was kind of a challenge at the beginning. Okay, so I'm going to go back here and show you a video of, this is me breaking a cord in a patient with upper extremity cording. You can see the cording there is pretty thin. We've got pretty tiny bands. They do kind of look like that guitar string that some people will relate them as. And so this patient does have lymphedema, and she had a decent amount of lymph nodes removed, but not a huge amount. And so I am able to be fairly aggressive with her. I am putting pressure where it adheres in the axilla, and then getting right down on that distal end and applying that 2-directional pressure. So I was able with her to get most of those bands to break, and she no longer had that pain. Initially, she had the pain all the way from the axilla right down to the elbow. Here is another video. Again, here we've got a really thin band. This is a different patient. She only had sentinel node removal, but she did go through mastectomy more prophylactically with implant placement. So she had a lot of trauma to the chest wall and repeated surgeries with expanders and things like that. So I think that's probably why she got the cording. She's doing much better now too. She doesn't have the pain or sensitivity, range of motion is full, and no pulling anymore. So again, getting right on those little bands and giving that kind of 2-directional pressure. All right, and then I wanted to show a video here also of truncal cording. Unfortunately, by the time I took this video, I had already broken most of the cording in this patient, and you can actually see a little yellow spot from where she had a little bit of bruising. But she does still in this video have a little band right there. You can see me kind of tugging on that. And again, just getting that 2-directional pressure going and breaking that band. And yeah, she did quite well here too. She had the cording in the upper arm all the way to the elbow and then through the trunk there as well. All right, so that's the technique I use most often when I am breaking up the cording. It's really that 2-directional pressure. It's really finding the starting point and the ending point. If I'm not successful there, I might move in a little bit. The thin bands are of course easier to release. Anything that's really thickened or has been there for a long time is going to be a lot harder. So we'll look at some options for that here in a moment too. And then I just wanted to show a picture of axillary web syndrome with radiation burns. You know, obviously when a patient has this much going on, we want to be really gentle. During the radiation process, we're pretty much just doing mild, gentle MLD. And, you know, unfortunately, because of all the scarring and adhering that goes on, we can do some stretching and some myofascial release techniques to this patient later, but probably not going to be able to break that cord because it's just been there too long and has been thickened and all of that stuff, unfortunately. But we can still stretch. This patient was still really tight and actually had a hard time getting her arm up for the positioning for radiation. So we did still do a lot of scapular stabilization and some prolonged stretching with her. Okay, so for some of the patients like this where it's a really thickened band or it's been there for a long time, one of my favorite techniques is from Thomas Myers Anatomy Trains. So this is, again, you know, a different certification that you have to take separately. The book is really great. It comes with a DVD. There's a lot of different techniques, but I actually use his technique for releasing the serratus anterior for cording. So in this video, this was the patient with a lot of hypersensitivity. I'm getting her on her side with her knees bent. Her elbow is bent with her hand relaxed by her ear. And then I'm just holding down right at the start of that axillary cording. The patient then is going to go and do both little circles and big circles and go both directions. This really takes the slack out of everything and allows the patient to really pull as much as she can tolerate onto that cording and help loosen and stretch that tissue. So this patient in particular would report, you know, not feeling so tight after she did this procedure, like it really felt a lot looser and could move her arm a lot better. And you can see from the video how tight that cord is and how thick it is. All right. So another of Thomas Myers' techniques that I use a lot in the clinic is the release for the pectoralis minor. Almost every patient that's gone through some type of breast surgery, you know, has tightness in their pecs and rounded shoulders. And a lot of people say it feels like they're wearing a belt. For this technique, again, you'd want to be trained in this and, you know, fully know how to do this. But you're going to, again, take the slack out of the fascia. So the patients actually have flat legs and they point their toes up towards the ceiling into dorsiflexion. They take the unaffected arm away from the affected arm and put it up out to the side like a stop sign. And then they have to also look away from their affected arm. The therapist then finds the tight area or that trigger point area and applies pressure there and just kind of holds it stable. And with all the slack out of the fascia, the patient then can really pull and stretch into that area. This is not that fun. It's kind of painful for the patients. We usually do maybe 3 to 5 reps. And again, afterwards, the patient's subjective comments too are that, you know, it feels a lot looser. It feels like someone unbuckled that belt that had been around them. Now, I always, even with these techniques, finish it up with more manual lymphatic drainage, especially if they've had a, you know, significant amount of lymph nodes removed. If it was just a sentinel node, it might not be that important or imperative. All right, so those are the manual techniques that I wanted to kind of share tonight. And next, I want to just talk about some compression options, some of the things we've done with some of these patients. All right, so all of us should know wrapping with our short stretch bandages. It's, you know, really useful for reduction, that high working pressure, low resting. We use everything that you can possibly use. We make a lot of chip bags. We use that really dense complex foam. We use the channeled foam. We use swell spots sometimes even with our wraps. And then there's a technique I want to show you later that we call the fan for the dorsal hand. It's something that my original mentor taught me. So I do want to show you guys that. So here's a video of me preparing this wrap. It's basically rolling it towards you and back and making 4 different accordions. The benefit of using this on the hand is that it really applies a lot more layers to the dorsal of the hand and reduces the amount of bulk going through the palmar surface of the hand. So when I was first trained by my mentor, before I even went to any courses, this is how we wrapped all of her patients. And I have found it to be really useful because of that reduced bulk. Patients find it more comfortable, and it does a good job of getting more reduction to the dorsal hand. So I'm going to show you a video here. This is our patient with the phalloplasty. So we kind of broke every rule with this patient. We started out with our standard, you know, finger to axillary wrap, and his hand got worse. Then we thought, okay, well, let's just wrap to the elbow. Well, his hand got worse. That, well, we'll really pad in the forearm. And hand got worse. So we ended up by layering this use of all this Kinesiotape. Then we're actually using, I'll start showing you the video. We're actually using a custom flat knit glove next. We're then adding on finger wraps. Most of the time, we also put a swell spot on the dorsal hand or a piece of dense foam. We did use that complex orange dense foam also. And then we're also doing the short stretch bandage. In this particular video, we're just doing the custom glove and the finger wraps. And I'm going to kind of skip ahead here and show you how we put that fan on. So we found that unless we put a ton of compression on this hand and nothing on the upper extremity, we were not getting results, not getting the results that we should expect and really want. I think things were just so adhered at the forearm that even the slightest pressure there was really causing more blockage. So we just kind of adapted and just kept layering. So this is actually less than we did most visits. We often had that foam in there as well. And you're seeing this pretty close to where he's getting full reduction. So I don't have any videos of kind of showing where we were struggling a little bit more with that. But there you saw the fan go on. So there's a little less throughout the palm of his hand, makes him a little bit more functional, especially with all those layers on. This is the patient that went through surgical debulking. And so we did pretty much a standard wrap on this patient, covering any open areas to begin with. You know, using sterile Kerlix and gauze and that Salona just to protect post-surgically. She does have that incision all the way from her wrist up to the axilla. But I did want to show you that hand wrap again because I also did the fan. And this patient also, both of them actually that I showed, really need the function of their hand for their jobs. A lot of computer work, a lot of fine detail work. So this really helps them be a little bit more functional by having that dorsal part of the hand more compressed and then less bulk through the palm. So you see the fan on there all the way up to the base of those fingers. I am putting the little fold in there as I go through the thumb and that web space, making sure we get good coverage all the way up. And yeah, kind of alternating back and forth above the hand, the thumb, and below the hand, just like you would without that. All right, and yeah, once you kind of get down to that end, just take it down and tape it down. And the rest of this wrap was pretty standard. We did a couple herringbones in a row on that forearm, making sure to diagonal at her elbow with a lot of padding there. And then pretty light compression going up with that 12 centimeter at the end. So we have that good gradient. So pretty standard wrap. And just showing a picture of that. That video was about 5 minutes long, so that's why I kind of skipped through some of it. But so our phase 2 compression, we like to use nighttime garments a lot. We use ready wraps a lot for our patients with mechanical blockage. And then for any of those that have real severe, going for a stronger flat knit garment with a higher containment like the Exo Strong. If it's more of a prophylactic or like a stage 1 lymphedema, we'll use the Exo Soft a lot, or a similar lighter containing garment. We do use a ton of swell spots too for all over the body. We'll use them under wrapping with nighttime garments, with daytime, with Velcro garments, kind of wherever they're needed. So this is just a picture of Exo Strong, that higher containing. I do like these garments too because they're seamless in between the fingers. They're quite comfortable. They're pretty easy to get on. And of course, the price point is really nice as compared to a custom, of course. And you get some of the same results because of that flat knit and that high containment. This is a picture of a ready wrap. So we use these patients a lot in either a patient that would have a hard time getting on a sleeve, or maybe the skin integrity is not quite there for putting on a sleeve. But we also use them a lot for our patients with mechanical blockage. And part of that is because we know that there's going to be fluctuations, sometimes as their disease progresses, and various things, or as they're going through chemo, sometimes they'll actually improve. So this gives a lot of versatility to a patient that's going to have more fluctuations. This particular patient loves her garment. She could be a spokesman for Ready Wrap. So I asked her if I could take a video of her putting it on. And what I loved about this video is she lets me record it. And even with some downtime here, it's like a 30-second video. So I'll just let you guys watch her put it on. And she can do this herself. And she does have a spouse that's helpful, but she, likes to be independent and is really happy to just put it on. So she's showing her elbow there and where the elbow should go. And kind of talking, actually, she was kind of walking me through it in this video also. But I love that even with some of that extra stuff, it was still 30 seconds. So that's pretty awesome that a patient can be independent like that and do it so quickly. So there was a little gap in there, she could probably handle going through and tightening that in some places again, but still pretty easy for her to don and doff. All right, so this is a custom flat knit. This was the patient with the phalloplasty. This garment really it worked good. I mean, it had high containment, but unfortunately it started to cause some skin breakdown in those web spaces because of those thick seams. The thumb part was actually made too long, so he's got it folded over there, and then had a really dense pad in here, a dorsal pad. And so that actually caused him to have some lymphorrhea for the first time ever. So it was like the containment was really good and it's what we needed, but it still was causing other issues. So we actually moved into a Exo Strong seamless glove, a medium, and that worked really well for him. It was not giving him the skin breakdown in between the web spaces. Doesn't have the seams. So there's a great picture I'll show you in a little bit here of what this glove does to the patient. And fortunately, the Exo Strong did not do that. Unfortunately, he lost that one, and I have not been able to get a picture of it. So we'll have to work on getting him another one. He's alternating back and forth right now between this and a nighttime garment. We're also going to get another custom garment made, so he has some better options. I just wanted to show a picture of some truncal compression. This is, a bra type. You can see it's kind of rolling up where the problem area is. but there's all kinds of different t-shirts and tank tops, camis, that type of thing, full long sleeved shirts as well. So we kind of use whatever works for the patient. Okay, and then I wanted to touch base kind of the final topic here, or final large topic would be some nighttime compression. The L&R products, the Tributes, are really great. The thing I really love about them is they have this irregular chipped foam. And because of that every piece is cut a little differently. It's very similar to our chip bags that we use in the clinic. So there's a lot of different contact points with that. It conforms really easily to the patient's body. And then it has that varied density. So it works just, kind of like our chip bags that we use in the clinic. So I'm going to just show a photo here. This is a custom Tribute night for the upper extremity. This, you can put a jacket over these things too. I don't think she had one. She really loves this. It helps keep her reduced without having to ever wrap, and not be in such a higher containing garment. So this is actually my violin player patient that had the rotated cording. All right, and then this is a patient with mechanical blockage, quite severe lymphedema. There's lesions all over her chest wall that are exposed that you can see. She has been dealing with this for quite a while and has gone through various treatments. She has 2 nighttime garments and she loves them both. But as you can probably tell from the picture, she really likes this one piece. So the hand and the upper extremity all in one. The other one that's 2 pieces, she likes and she does use, but she finds that it sometimes might gap a little bit at the wrist, and it's obviously not as functional with that much on the hand, and she can kind of get away with not having that much coverage. So she loves the second garment. And when I asked her if she'd come in with that one on after sleeping in it overnight so that I could take a picture, and she said sure. And when she came in, I thought, oh my goodness, girl, you need a new garment, because this thing is so flat. It's like as flat as a pancake. It has no cushion in it whatsoever anymore. I mean, she has used the heck out of it. So he was like, you really need a new one. This can't possibly be helping you. There's nothing left to it. And then she took it off and I was like, oh, wow. I'm really amazed, because it obviously is still really working well for you. So the one on the left there, it's kind of the full arm. So this is after her wearing it all night and coming in the morning in the clinic and taking it off for me. So obviously really breaking up that fibrotic densidema that she'd had. I've never seen this on her before, because we see her midday or in the afternoon after she's been wearing a sleeve or a Velcro garment. So it was really cool to see how well the nighttime garment works for her. The one on the right, you can really see those channels, those chevron channels that are really helping that lymph flow too. So I thought that was just a really cool picture. She still could probably use a new garment because it's just going to give her even better results. But I was amazed at how well that really old, thin, worn out garment was working for her yet. So, okay, so I do want to show you a couple swell spots. They're all shapes and sizes, of course. I'm sure you guys all use them. We just kind of get creative with them too and use them wherever we need to. This is actually the patient that donned her own Ready Wrap. We found that the glove was not quite containing enough for her. So we did add a swell spot into the little pocket here and had her try it on in the clinic. We helped her out because this was the first time of her getting it on, and wanted to just kind of see if this might work and give her a little bit more containment on that dorsal hand, so that she didn't necessarily have to buy a new garment, but maybe just a smaller swell spot. And we left that on for just a couple minutes and took it off, and you could already start to see some of the results from that swell spot. So she was going to go forward with that and yeah, not have to buy a whole new glove, which was really nice. So, all right, so that's kind of the end of the compression, and just wanted to touch base because I feel like I have to be thorough, that it is also important for all these patients to make sure they're exercising. I love swimming, and yoga and Pilates are great for people with lymphedema. Also foam roller exercises, of course, working on that posture and that extension. Pec stretching, very often, very important. The cervical retraction, scapular retraction, mid and lower trapezius strengthening, and rotator cuff strengthening also, of course. Always telling my patients to start slow, start with low weights, low reps. The biggest thing is not to hurt yourself. You don't want to pull a muscle. cause any trauma, basically, because that could worsen your lymphedema. And wear your compression sleeve. You want to make sure you have that on. And then skincare too, also important, just to make sure that they are hydrating, especially out here in the desert. It's super important. Patients get really dry, especially when they're covered up all day with their compression. Making sure they're still washing regularly, taking care of those nails and avoiding injuries. We just don't want any infection. And then I always say, probably other than like the manual part of our CDT, probably one of the most important things is the education, because we really have to teach our patients to be independent in caring for this lymphedema themselves. It's not going to go away. It's something they're going to have to manage for the rest of their lives. So I really try hard. I mean, the National Lymphedema Network puts out their risk reduction practices, and we always give our patients that information, teaching them about the signs of infection, how to do their own self MLD and or have a pump, hopefully an advanced pump. Of course, their compression, how to maybe self-wrap, self-don, how to care for that equipment. And then self-kinesiotaping, if that's beneficial. Some patients we even teach to self-cup. Occasionally I've had a patient get an iStim tool themselves. So whatever's benefiting them, if we can teach them to do it, I think that's always advantageous for the patient. And then of course their home program, their exercises, and that skincare. All right, so pre and post. This is that post-surgical debulking patient. This is not really post CDT, but this is after 4 weeks. So I think she had about 6 treatments in here, but you are starting to see the reduction already, especially if you look at the dorsal hand, you can see that's come down quite a bit. There is some bubbling just because we had just taken her wrap off. You can really see the demarcation where they stopped the surgery and didn't debulk anymore. You can actually see that in both pictures. It's a little more pronounced on the left. And as we're reducing her, it's becoming less pronounced. So she's getting some pretty good results pretty quickly. This is another picture of her. Again, this is 4 weeks. So you can tell that incision is really healing. If you look really at the wrist and elbow area, you can see that reduction also happening. There's a lot of that post-surgical fluid that's really reducing with the short stretch bandaging and the CDT. All right, and then our patient with the phalloplasty. So the one on the left is before he started any therapy, and then the one on the right is near the end of therapy. So quite reduced there at the wrist. You know, he kind of had that Mickey Mouse hand, unfortunately, to begin with, but quite reduced, quite flat there. Also, you can see the keloiding has gone down quite a bit in all of those incisions and scar tissue. The color has greatly improved. The integrity of the skin has greatly improved, and really from a distance you might not notice. Whereas, you know, initially it's quite obvious that there was, you know, a surgery there. This is just a picture of the hand. So going again from before treatment to after treatment, this is the picture where you can really see the seams from that custom glove, whoops. And also from that really dense dorsal pad. But then there's just a complete before and after. So right after surgery, going to the end here of CDT, we are still seeing him occasionally here just for some tune-ups and make sure we get the right kind of compression. A big, huge part of his success has also been a nighttime hand garment. He's the only patient I've ever just put in a nighttime hand. So he has the tribute hand wrap that you saw in another photo there, and wears that nightly, and that really helps keep him down between that and the custom glove and the Exo Strong that he was using. Without that nighttime garment, we were really still quite struggling to keep things reduced. So still taping for him, still nighttime garment, and then that flat knit higher containment. But he's, you know, I think quite pleased. I think he was hoping that he could get all the way back to normal and not have to manage this arm. But with everything we went through, kind of trying to break past our typical treatment styles, I think we did really well with him, and he was very pleased. I do feel that this is something that's probably going to come up in our careers a lot more. We're seeing that transgender reassignment surgeries, both the mastectomies, which, you know, I've seen can cause some complications, and as well as these phalloplasties. So I think it's good to start sharing our ideas with them. So yeah, just a review of all my key points, and a big thank you to LNR for hosting this webinar again so that we can share and learn and help our patients.
Thank you, Deana. That was great. So we do have some questions in here. Anyone else that has questions, please drop them into the Q&A box, and I'll start going through them. Lester asked, there is research that was published this year that lymph flow in the upper quadrant still drains to the ipsilateral axilla and not towards the inguinal nodes. The research said that it might not be possible to reroute and that MLD should be done with ICGs. What are your thoughts?
Well, I actually have not read that, so I'm not familiar with it. I'd like to look it up. I mean, we generally use the AAA and the PAA and the right AI if we're doing drainage. So we do use all of them. So I don't know. I mean, I feel like we get results going just to the AI as well. So I don't know. I'd like to read more about that and learn more because we want to be efficient too. So if it's not draining as well to that inguinal region, we want to spend more of our time going to the, the opposite axillary region. So yeah, that's really interesting. I'm going to look that up.
Thank you. All right. With negative pressure like cupping and some of the taping techniques, are you ever worried that this would further move fluid into the interstitium with decreased interstitial pressure?
Yeah, I mean, I think it's something we have to be careful with, and that's why we're really like moving with the flow. We're not holding for a long time. We're not causing that bruising, and then generally doing it. So for instance, the patient with like the phalloplasty, how adhered that was, there was like no chance of that happening. In fact, I think we might have been a little bit happy if we got something like that to happen because it would be lifting that tissue so much and allowing some flow there. But I think with any of these techniques that are deeper, you do have to use caution. Someone has severe lymphedema, you don't want to go real deep. You want to make sure you're doing a lot of MLD before and after, and then paying attention to how many lymph nodes they've had out. I mean, the patient with the phalloplasty had 0. That wasn't the issue. We have a lot of patients that have just sentinel nodes. So really looking by case.
Awesome, thank you. Which anatomy training course, I think it means, would you recommend? I just checked out the website and there was a few different courses.
That's a good question. I haven't looked at that for a while. I have the book and the DVD and did the course quite a while ago. But if you're specifically interested in that upper quadrant stuff, I guess looking at that, if he has one that's more focused on that, because there's a lot of different trains throughout the whole body. So yeah, I don't know that I can really suggest. I'd kind of have to look at the list again. But yeah, they're all going to be good. They're all going to be useful, for other patients you see too.
Let's see, what brand of tape do you find has the best adhesion?
Good question too. We actually use the TheraBand one a lot and the actual Kinesiotape. For whatever reason, all of our patients always say the black sticks better. The tan comes off right away. So I only have black in my room anymore because everyone tells me it. They're supposed to be exactly the same. I have no idea why the black sticks better. That's what they tell me. Yes.
What is your recommendation for frequency for seeing patients with mild lymphedema and axillary cording? Do you just do MLD for every mild case of lymphedema, for example, stage 1 until they get garments?
For a stage 1, we might only see them once a week for a few times, mostly just to teach them and yes, get them garments. If they have cording, it might depend on if we've made progress or if I think we're going to be able to break it. Sometimes the other therapists I work with will schedule them specifically with me and say, hey, they've got some cording, I think you can get it. So it kind of just depends. So I might just do like 3 or 4 and then like, oh, we didn't get it yet, but I think we can. Let's do a few more. Yeah, so it really kind of depends. But if they're less severe, once a week is often what we do.
Awesome, thank you. And it looks like Lester shared with everyone a few of the different articles. So thank you for sharing that with the group. That's awesome.
Thank you.
Let's see, next one. Do you have any suggestions on how to do the dorsal fan where there is a large dorsal hump with a huge drop off from the top of the hand to the wrist? So it has a skinny wrist with a large forearm.
So that's really similar, it sounds like, to the patient with the phalloplasty. When we started, I mean, the video I showed of it, it was improving already. Really what we found was just to do very, very little at the wrist. So putting that fan, all the way up to the base of the fingers, down to the wrist, and then really doing most of the wrap on that part. So not going below my finger here or the wrist line, kind of, above and below. And really just that last time around going at the wrist, really gently. I would put a lot of cotton padding in there. That's not going to add pressure like Solona. I wouldn't do anything dense. I would just try to build up that area. If that wasn't enough, you could try something like an ABD pad in there, but something that's not super dense to just kind of build that up and then wrap from there on up. That's my best advice.
Thank you. For Tom Meyer's course, which one would you recommend? So I think that might have been the same person.
Yeah.
So I think I might just put that in there. Okay.
Yeah, and we actually had a traveling course come into our clinic, and we all learned from each other and took a whole day. So I haven't looked at that for a while, so my apologies on that.
Let's see, that one's done. Do you have any suggestions for post-mastectomy trunk and upper extremity combined compression?
Yes, I actually like that Italian company called CS Zallis. They have just an all t-shirt thing. It's ribbed, it's pretty comfortable. So it kind of covers all the way from the wrist to the neck and down to the waist. So it's something you can even find on Amazon or order directly from their website. That's one of my favorites for trunk. It's a hard thing. There's nighttime garments are really good, the vest and that, but it's hard to find something comfortable to cover your arm and your trunk without leaving any gaps. That's really going to work. So yeah, if it's a stage 1 or so, something like that would work well. Otherwise, you kind of have to layer. You have to do, the more aggressive needed for the arm, and then layer it with a tank or a cami or a t-shirt. Yeah.
Thank you. And they had asked, can you please repeat the name of the trunk arm garment company? Or maybe if you can just type it in the chat box.
Sure. I screw up sometimes, so I want to make sure I have it right. Is it C? It's CZ Salus, CALUS. So CZSALUS. So they have some good upper extremity. We also do the wear ease sometimes too, is another one we use. But I think there is some room for better upper and trunk and upper extremity garments too.
Awesome. All right. So we might need more context. We had a question that said, do you use foam? I know that you definitely use foam, but if you'd like to comment on that, and yes, if you have any more specifics to the person who asked that question, please feel free to type any additional details.
We use every kind of foam possible. My boyfriend used to work in the pharmacy, and he'd bring home these chunks of foam that would medications would be packed in, right? And we'll chip it and we would channel it ourselves, and all different kinds of densities. I've got super dense to all the way to really soft. And yeah, we love the channeled foam, sometimes just a little strip somewhere. We use every kind of foam possible. The orange gold foam that we call the Comprex, we love that. So yeah.
Awesome, thank you. What is your thought on using Under Armour clothing and Comprex for breast scar tissue after radiation? Most of my patients cannot afford the garment or are able to do the ML multi-layer bandaging for the breast edema.
Breast edema, I tend to just like a tight cami and a swell spot. I mean, if you want to make your own chip bag, if that's better, but the swell spot, I mean, it's kind of an area you want to wash easily too. So those swell spots that you can throw them in the washing machine, you can get any size you need. I mean, sometimes we'll make a chip bag first with maybe the Comprex and some other different densities and have them try it. I don't use Under Armour stuff myself, but.
Awesome. Do you use any adhesive short stretch or long stretch bandages?
We don't in the clinic. We've seen them and tried them, but I don't know. We kind of go with the old school. Yeah. We do have some wound care facilities. I tend to see that they can kind of roll a little bit still. So I don't know. We don't really use them ourselves, but.
All right, it looks like we had a few more people send in questions to answer the name of the company. I did type that in to the chat box, so feel free to check the chat box. I did type that in, but it's CZSALUS for anyone else that has any questions there. So I'm not seeing any other questions. I am seeing some comments. Thank you. Thank you for sharing your experiences and your techniques. Thank you. Thank you to Lester for sending over the links to everybody for those articles. All right, well, it looks like those are all of the questions unless something else comes in. So thank you all for joining us today. It was great to have you. We really appreciate Deana's time and all of her hard work putting this together to share all of her experience in the clinic. And we hope you all learned a lot to bring back to your clinic to help support your patients. So thank you for joining us, and we hope that you all have a wonderful night.
Thank you.